process that would impact your day-to-day. And so really what we wanted to look at was how can you strategically plan based off the information I just presented. And the way we wanted to look at it was, it might be for me. I got like 17 of those jokes. I never know which one to use. I just went with that one. They're funny to me, so that's all that matters. Thank you. Somebody laughed really hard. I'm gonna get you a drink tonight. Really, what we wanted to do was run through the exercise to say, okay, what can we do in a year and what can we do in 5 years? And to make it palpable for you. So I brought one with me. This is just an example. I'm sure you all have seen gap analyses before. With this particular one, it's what do we actually do and what do we know is desired? So for example, in this one, there's little focus on self-management. How do we assess and manage risk and the desired? And then there's surgical intervention model predominates. How do we get to something that's a focus on prevention? And then the idea is what is the action plan? And so for the first step, what I would like you all to do and to share is where are we actually? And not to think about that antiquated dentistry, as Dr. Evans says, Dr. Smith at 444 Main Street above the grocery store. Sorry, I had to evoke it. It's okay, yeah, that's close enough. Yeah, I'm paraphrasing. That's not a direct quote. He'll give me later with the direct quote, trust me. What does it look like? How close are we? So when you think about where we're at actually, of all the things I just presented, what are those things that are palpable in the majority of the area where you're at? And so I'll kind of start there and throw that out to the audience, and please don't leave me hanging. I will look really bad. And I took this very seriously. If you notice, I actually matched my hair to the pinstripes in my suit. I did that for you all. All right? So let's see where people think we're at. How close are we to what we discussed?
Thank you. My name is Terry Chandler, and I'm the Executive Director for Future Smiles. We're in Nevada. So our Practice Act is pretty liberal. We practice unsupervised in a school-based health setting and can provide full scope of practice as a dental hygienist. So we are also eligible to bill Medicaid. So we are in the Medicaid payer system, which is also unique. One of the things that I have noticed, and maybe you can help me with this as far as an opportunity for improvement, the Medicaid system will only pay for a dental sealant once in a child's lifetime. I don't know about you, maybe your sealants last for a lifetime, but ours, lots of times they need to be touched up, they need to be reapplied. So if the system itself isn't providing preventistry and isn't covering the cost of a replaced sealant, then the child gets decay. So how do we talk with the insurance companies to be able to get them to understand that it's critical that the sealants are covered more than once in a lifetime? Anybody else experiencing that in their Medicaid systems? And what happens in the private sector, so we're a nonprofit, so that's where a lot of our funding comes from, is from grants and the philanthropic world. In the private dental office, they won't even touch up the sealants. If they can't get reimbursement for a preventive service, they're not going to cover it. They're not going to do it. So that's an area for improvement. Any ideas?
Yes. Anyone else?
Hi, I'm Dr. Kapoor. I'm the State Dental Director for Nevada. I just want to make a comment on that because I'm also the Chief Consultant for our Medicaid. So we see this problem in the community. We want to change it. We're currently revising all of the service limits within our Medicaid benefit schedule. The problem is we have to do a fiscal analysis. How is this going to impact our funding? Does Medicaid have enough money? So we see the problem. We have stakeholders that want us to change it, but we still, and we have people in place that can make the change, but then we have a funding issue, and we seem to keep coming up against that in oral health in our state. I don't know how we fix that kind of final problem when we're all aligned, we all want to make this change, and we can't get there at the end.
Can I ask a question just from that standpoint and to get to sort of Sean's slide 2, is to what extent is the Medicaid program looking at risk. If we're now looking at sealants placed based on higher risk kids, how much is the Medicaid program to the sealant issue willing to actually look at risk stratification so that you can better manage the dollars that you have?
I'm taking it all in. I promise I am not sitting up here. I am just waiting to make sure. So, first, I will not solve the world's problems today. All of you are looking at me as if I can. I cannot. What I can say is there are a lot of things we do not know that stand in the way from that actuarial piece. The problem that we have in dentistry is the actuarial individuals are not really looking at the system as a whole. So the things that we have to understand is what is the yearly failure rate for sealants and how much does that cost? How many of those patients are coming in and going to some sort of surgical intervention rate and having a surgical intervention after the sealant is placed, because it goes back to risk. If you want to look at the future, so if I can just take us up to that desired state, to me it's empowering those practices that they can make the decisions on the sealant routine because they are getting a payment up front, either in a bundle or in an incentivized payment structure that will allow them to treat patients for what they need. I can't remember who I was having the conversation with yesterday, but the question I had was, at what point, I think it was you, Doc. I'm bringing you back in, but I said, at what point did the benefits structure start dictating standard of care? And so I am going to take a 60,000-foot view and say, well, that is ultimately the biggest problem. And so there has to be an understanding of what's best for patient. What's it going to take for people to look at risk stratified pieces? Changement in that reimbursement structure. So that Donna Bedian that I had you draw, the process is the change in the financial system. And in order to get there, we need more knowledge on predictability. So I will tell you, I'm going to do it, Avery. I'm going to let people know some of the stuff we're working on. He always gets nervous because it's not all the way done. But we are looking at yearly failure rates for sealants versus silver diamine fluoride versus fluoride varnish. That way we can inform our practices. If you do this as an intervention model, here's what the cost is going to be on the other end. So then if we bundle those preventive payments, they have predictability in what is in place. If we know where the failure rates are at, we then can, on the other end, develop incentivized payments that help to decrease some of the risk or the concern from the variability in the patients that they see. For example, it's really unfair if you're assigned 15 to 16% of your patients as special needs patients. So how do we overcome that within incentivized models? So there is that. How can I help you in Nevada? By getting that research out and talking about it the same way I did here. I think the issue is always going to be, we have to make it okay for providers, organizations that are providing the care to take that risk on. And that is what I'm hearing from you that providers are worried about, right? They put one sealant on, they have to keep up with it, and truthfully, some of them are rooting for it to fail. And so those are all things that are part of the culture that is very difficult to change. So I think I answered your question 30%. I'm hoping that's at least 15% better than you've heard in the past.
Yeah, something that I haven't heard raised yet today that I think is actually really essential in terms of defining what value is at the end of the day are diagnosis codes. And we have them. And they're aligned with ICD, and they're aligned with the international system of codes. That code set is done. It's evolving, but it's done. And there's also interfaces for the various electronic medical records. I don't explain to me how you can possibly define value if you don't have a diagnosis. That doesn't make any sense to me at all, and it certainly doesn't make any sense to me when you're trying to look at what came up earlier about sort of choosing wisely and looking at what works and what doesn't work when you have a diagnosis. So when are the payers who are supposed to drive this system of accountability and value going to mandate that the code set that we have, that we train our students on, is actually used in the payment and billing?
I love facilitating the first session.
The tool is there.
I know. I'm just waiting. I'm making sure, making sure there's room for other comments.
Or response.
Just coupled with that, since we're on the diagnosis codes, the new hemoglobin A1C that was added for dental to use, what have you been hearing from states as it relates to pushback with the ability in that being a part of scope of practice? So now we have the inclusion, but some states are having trouble with that. So.
All right, let me take the A1C question. That's the easy one. We're not ready for the A1C. We have been working with our medical, in those interprofessional networks, we are seeing diabetics. Looks like we're going to have a little bit more success in Oregon because they have the thing that Oregon did that was really smart is the states own the health information exchanges. The biggest issue is we have to be able to connect into all those independent, varied electronic health record systems. And there's a little loophole in the ACA that says if it's a health information exchange, they have to open a window. We were beating our heads forever trying to get them to just work with one another. So we said, well, screw that, we'll just do the health information exchange. We're not there yet. Where the issue is with the A1C is we can't give a patient-level report. If I'm a dentist and I have a diabetic coming in, I can get a report that tells me what I'm doing per month on all my patients. But I cannot see what the patient's A1C is without a large amount of FTE being expended where it costs too much. And so that's when I say the triple aim eats itself because the cost goes up and that destroys the experience of care. So that's the biggest issue that we have now. Where we would like to get, and if you believe the same as I do, that medicine is the master and is going to become even more of a master in this system, is what dental organization sites, practices will need to do is to talk about how they're effective with their A1C. So just how medicine has to report, here's the percentage of patients below 9, dentists would do the same. And we're working on that in Oregon. Same thing with blood pressure. Are they within those guidelines? So the issue we have now is we don't have the technology that is going to enable our providers to do this in a way that's affordable. And so we have to start there. I'm a little concerned about the A1C measure because it should be a pilot measure and it should be worked out for maybe 2 to 3 years, and everybody seems very gung-ho on just getting it in. And if I am a dentist and I can't tell my patient or I am not communicated what the A1C is, and for most parts, in some states, those practice acts you talked about, they can't even do a finger stick. I will tell you in South Carolina, the Lab Tech Association beat us over the coals. So we ended up just having our assistants become certified phlebotomists. And then we actually sent the stuff out to the lab. It worked out really well for us. Go ahead, Lynn.
Yeah, Lynn Mowden with Guardian Avisis. On a couple of issues, first of all, the A1C. We are doing a pilot, and we're paying the dentists as a value-added service. We're paying out of our pockets for them to do the finger stick. It was a long, complicated process. Had to get the dental board to agree, as you know, as always. We got Henry Schein to donate the kits. We're paying for it. We're even putting in a little extra to the docs just for their time and effort, whether there's a finger stick or not. And the best part is, if they are identified, and I forget the number, if it's above 6, I think is the threshold, it gets reported not only to the patient, but also to the PCP and to the health plan. So lots of complicated things to make it happen. On the diagnosis codes, it's not going to happen until CMS makes the decision that all claims have to have a diagnosis code. Now, when there was a chief dental officer at CMS, it was being pushed pretty hard. And for those of you who don't know, there's no longer a single dentist working at CMS, so talk to your congressman.
And correct me if I'm wrong, Lynn, but not only does it have to have to be mandated, but it has to be enforced. And so at the state level, they have to enforce it. And so they have to make a decision if they want to do that or not. Really where we're at with the ICD-10 codes is why I know the system is in place. What seems to be a struggle is an incomplete code set within medicine, understanding what those are. Because what medicine wants out of it is verification of what the disease is, so that then that gets uploaded back into their system. And so while there is technology to help the dentist, the ability to communicate that effectively back to the medical folks to close that loop has been quite challenging for us. So much so that we are literally using paper and fax to get the ICD-10 codes put into the electronic health record system by a referral mechanism because of the inability of practice management software to allow that to happen. And so while we might be able to have dentists doing it, if they're doing it in a siloed atmosphere, all we're doing is integrating A1C, and we're not actually working as a team to make them healthier. And so the goal for us is how do we make them healthier in that process? So I don't have an easy answer for you. I can say that I know the Dental Quality Alliance is looking to remap a lot of those codes to understand where the CDT codes are at, to try to, and also to involve folks from medicine to try to help us make sure we have a better communication system. So,
can I ask a question? No.
Yes, please.
I'm curious. So for those of you who may not be able to see very well, this says applying evidence, changing processes, training workforce, educating parents, using information technology, and aligning payment. I'm curious to see who in the room has had success in closing the gap using those suggestions, and if they wouldn't mind sharing their success stories, if anyone's done this well, just an example. Yeah.
Hi, Shirley Spader, Rhode Island. In a past life, I directed a hospital-based residency program and clinic. We had success in two areas. Hasbro Children's Hospital, based in Rhode Island, we started a grant-funded hygienist-driven fluoride varnish application program, worked with pediatric dentists and their staff, trained them. Unfortunately, the grant funding ran out, and the hygienist found a position in private practice, but it was successful. And the second area of success that we had was working with third-year medical students at Brown University Medical School about 15 years ago, and incorporating training, having them spend a couple hours in our clinic and going through some pretty basic oral health educational pieces. And it was well received, not by all, but majority, and it's still going strong. So it was an innovative program to incorporate somehow, some way, oral health education into medical education at the ground level. And it created kind of this soft, we worked on a soft handoff referral process. And so just two bits, and they're still going strong. Thank you.
Yeah, that's great.
Hello. I'm being yelled at to stand up. I have to. You whispered, yeah. Well. Scott Howell. I teach at A.T. Still University, Arizona School of Dentistry and Oral Health, and we got a HRSA grant a few years ago to implement some interprofessional education and practice at community health centers that we work with. And our dental students spend about a half a day with medical students in an FQHC up in the Seattle area. And we wanted to look at the referral process, medical students being taught how to look in the mouth, look for signs of disease with the dental student. The dental student is also taught how to do some medical evaluations to better assess their patients. And then we tracked the referrals from medical to dental. And I don't think this is groundbreaking, but it's doing it within the framework of education to teach the students to be aware of what they have the capability of doing. And in our first year and a half or so of tracking the patients, about 25% of the patients actually showed up in the dental chair. Maybe 30% made appointments, but only 25 showed up. In 6 months since we started a warm handoff, and this was just, you need to go see the dentist, here's the dental clinic, it's upstairs. We changed the process to a warm handoff where the medical and dental student now walk the patient to the dental clinic. Our N is very small for the researchers out there. It's just a few people so far, but what we have found is that 2/3 of the patients showed up for their dental appointment simply by doing that warm handoff. And my goal as a public health educator and with these students is to teach them, you may not be doing this yourself, but this might be a system you want to implement within the clinics that you work within. And I think it was the IOM report that came out in 2015 that said this is going to be really hard to track health outcomes of all these interprofessional practices and behaviors. But I think that's something right there to show that we went from a 25% show rate to a 2/3 show rate with a simple change of walking someone to the clinic. And these are co-located clinics, so that helps, but it's something.
I just wanted to share, I think this is an in-progress success story. So I'm Angela Fields, and I'm the director for the Mississippi State Department of Health Office of Oral Health. And one of the things that we work towards, or are working towards now, is working with the Office of Preventive Health, who has a lot of programs centered around, of course, prevention and education and awareness. And in our state, we have prevention teams that traditionally oral health has not been a part of. And so with my office, I have about 7 what we term regional oral health consultants who are dental hygienists who do a lot of the grassroots community efforts. And so about a year ago, as far as training workforce, I think this is where it comes in. I've allowed my hygienists to train and do some of those self-management, chronic disease self-management classes that are offered through prevention, also with diabetes, so that they could assist those teams as far as going out in the community and providing education about why oral health is important to this chronic disease. And then also this year we added the car seat safety when you talk about nutrition and diet. And how, we know kids are in the back in the car seat with the sippy cup and what the sippy cup has in it. So we utilize these opportunities through the Office of Preventive Health to tag team. So I think that this is going to prove to be successful as we're training, team members who are traditionally trained in dentistry to be more like a community health worker. And as we expand the training for my team, then I think we'll be able to, go into other areas. In addition to that, we've been training social workers on various cavity-free curriculums so that when they go into the home, that oral health is a part of that. So I think these are some beginnings of some stories that we'll be able to share in a greater detail.
Any more success stories, examples of success stories? I know this is a successful crowd. Any thoughts, reflection?
I would love to hear more success stories. So let me throw this out. We talked a lot about challenges and facilitators. What were, in some of the programs where you've had success, what were those core facilitators that move things along? And Dr. Braun, I'll let you, because I saw the microphone went over, so I'll take a step back and say, forget what I just said there 2 seconds ago. Dr. Braun.
Yeah. So I hold my comments because I'm going to talk about this a little bit in my talk. But you asked about, so I'm a pediatrician and I do lots of interprofessional oral health work. And some of the stories that I hear from within Colorado and outside Colorado that are successes is that once you can get the message to the patient and they can get some knowledge and understanding that they do want to have optimal oral health and they want to have these interprofessional relationships that where the medicine and the dental side are talking to each other. So while there is this big culture gap and there's not enough oral health literacy out there, I think that there is potential for that if we can get the right messages across. So I have other comments about the payment system, but I'm going to let you move on. But that is one of the successes. We're hearing lots and lots of anecdotal stories. Both I'm hearing them personally, but I'm hearing them from lots of people with whom I work, that people want healthy mouths and they want care that gets them there. So I think the needle is slowly starting to move on that. It's slow, as all these needles are.
And when I was at my FQHC, we did an analysis of that. So we were integrating diabetic care, and we published, and find me later, I'm blanking on where that was at. But we did a survey to our patients, and we asked, were you aware that medicine and dentistry could work together? And it was, on that Likert scale, about as far down as you could possibly get. And then we said, is this how you prefer it? And it was not all the way up top, but pretty close. And then we asked, would you want to go back to the way that care was delivered? And the reason we asked that question is because I was getting pushback on our board because FQHC is all counter-based, at fee-for-service as well. There's a lot of pressure. And that was the highest rating that we had, that they did not want to go back. That the fact that they knew their primary care provider was talking to their dentist meant a lot to them. And so the problem we have is that people have no idea it exists really when you look at it as a worldview. But once they have it, they want to keep it. And that's opportunity to me. It's Graham Nash. You guys know Crosby, Stills, Young and Nash, I hope. He likes to say it takes so much to get the world to stop for 1 millisecond. But if you do, you better have something really important to say. I think we're really close to at least getting the world to stop and listen. And so making sure we have the right message is going to be incredibly vital. And thank you, Dr. Braun, for that. Yep.
Sean, great presentation. As I'm looking at the gap analysis and following this more recent discussion, I look at the gap analysis and think about what seems to be missing is the larger message. And where I'm going to is that I believe that most people follow the narrative that's been laid out that it's about smile. And that imagery of smile, we're going to give kids a smile, and it's all about smile. And clearly, personal self-image and feeling good about yourself is connected to smile. But that seems to truncate the message and really distort it in a very suburban type of direction. And I'm wondering, how do we change that narrative to have more traction? Because I think smile in some regards gets in the way of interprofessional collaboration, because why do I need to collaborate with you to improve somebody's smile when there are more important issues on the table? What is your thought, or what's anyone's thought in the room as to how we create a message that has more significance to more people and be more convincing and helpful, particularly in terms of a value-based system? Again, not that a smile has no value, but I don't think that that's really the key point, and helps drawing and attracting interprofessional collaboration.
So I'll throw that out to the room, because that is, I would love to hear that from the room before I chime in.
So I'm Meg Booth, I'm with the Children's Dental Health Project, and we have done some focus groups with influencers in communities to understand messaging better, particularly for policymakers, what would grab the attention of policymakers better. And hands down, without question, in all the communities we've gone to in a national focus group and 4 different communities in 2 different states, it's that we need to be talking about the impact of disease and not the prevalence of disease. The people need to understand that it's not about a smile, it's about employment, it's about school readiness, it's about all these areas. And so I think we need to stop talking about the disease process and talking about, all the things that all of us know in this room that no one actually cares about. People want to know how it impacts their lives, how it impacts employment, and all the areas. And that's true for policymakers too. But people don't know and don't really care that much, I don't think, about the nitty-gritty of how to get there. They just need to know, from a policymaker standpoint, that there is an impact on their community and something needs to be done about it. I think the other part of that we've sort of been looking at also is that we need to start talking to how we can help other professions, not just the medical profession, but are we talking to job training? If it's important to people to know if the impact is on employment, are we going to job training programs and saying, we can help you? Like, it's not the top list, top on your priority list to address the oral health, but we need you to understand this has an impact on your program's outcomes, and how can we help you, instead of not only can we come fix your problem, but like, you should send them over there. It's much more thinking about the integration of both the impact on the parent and the child, and the impact of their oral health on other systems of care, and sort of what we have to offer those communities to integrate oral health at a very basic community level, and how do we get experience doing that before we go to a systems level.
And I love the idea of what you said around involving others. In South Carolina, we found that the most influential person in health was the Medicaid car driver. They actually, the individuals trusted that driver more than they did the healthcare professionals.
Since you just said that, that opened up exactly what we do. Good. So I'm Tanya Fuquay. I'm a dentist in Fort Worth, and I actually am over child oral health for our local children's hospital, Cook Children's. And there are several things that we do, a multitude of layers. We started out in 1999 with the Children's Oral Health Coalition, just bringing the people together to the table to talk about what is everyone doing, or why are they interested in oral health to begin with for children. We're now well over 40 organizations in all these years that are congregate together to figure out how to move the needle with children's oral health. But besides that, we designed a program for Train the Trainer. And so we're training community professionals, not dentists, not hygiene, not anyone else. We're teaching other professions that are out there touching the community. So we're training them to train the community on oral health and the importance, so that we're changing behaviors. We can't just drill and fill and go on. If we don't change the behavior, they're going to be in the same situation they were in to begin with. The second thing that we've done is we then started a Save a Smile program, and that is a true integration of public health with the private sector. So we now have 98 dentists and specialists in our community that provide free dental care for the children in our community. We do that by having community health workers. We go into the schools, we screen the children. Again, here in Texas, it has to be by dentist. So our volunteer dentists, our private practicing dentists that come with us to our schools, we're only in 18 elementary schools, but in 3 different school districts, and we're at the most highest risk schools. And we classify the children, and then we get them to the treatment they need through our community health workers. That means making oral health a priority. You have to then go to their home, visit the parents, talk with the parents, provide the transportation, hook them up with a dentist, or maybe they already have Medicaid, but they're not utilizing it. Maybe they could qualify for Medicaid, but they're intimidated by the application. All that our community health workers provide, all of that, handing them off to the dentist, making sure they go. And I'll tell you, our dentists want to continue to do this over and over again because they know the patients are going to show up. We don't care if they have finances, they have whatever. If they have Medicaid, we'll provide the transportation. We'll get them connected. We'll get them to a physician. If the pediatric dentist notice something going on and they're concerned, we get them to the physician. We make sure that we follow up, follow through, and get everything taken care of. Food's not on the table, electricity's not on. When we do a home visit, all that's taken care of as well. So we have a master's level clinical social worker managing community health workers, and we're making lasting change. And in 16 years of doing that, our kids that we touch and we impact, they're staying healthy. And they're staying that way. From us touching them at as early as 3 years old, because we have early Head Start now in our schools, up till 6th grade. So it truly does take the village to raise the child and to change the behaviors and the mindset of those parents. Because we're so successful, Cook Children's now also has, and has for several years, have their fully integrated medical dental home. So we have one neighborhood clinic that serves the vulnerable population in that community, which they have community health workers, a child life specialist, dentist, pediatric dentist in that one side, and they hand walk them over to the physician when they see something going on, or the physicians hand walk them over, their nurses, to the dental clinic. And it's making a difference. And we're decreasing the amount of children that are needing OR dental care, which is the most expensive way to treat our children. So we know we're making an impact, but again, we're in 18 elementary schools. We have one dental clinic integrated with a medical home, but we're proving that it's making a difference. It's just a very expensive way to make sure that the children stay healthy.
I'm curious, is that gaining some traction in Texas, so it's going beyond your community?
Yes. So, yes, and I can talk loud. I don't need the microphone.
That's actually very true.
You and I do a show together.
That's my ex-wife.
Boom, boom.
Yes, we are making a difference, and the AAPD has noticed our program. We have a multi-year grant by the AAPD through Healthy Smiles, Healthy Children because of the success rate, because they see what we're doing. I get called by the AAPD, I get calls from the American Academy of Pediatric Dentistry, the ADA. They're wanting to know what the heck we're doing in Fort Worth, that we have a children's hospital that understands that this is connected to the rest of the body, and that we are trying to make a connection between oral health and overall health. So yes, we are being noticed, and yes, it's gaining traction, but again, like I said, it's one of the most expensive ways, because you're having a community health worker babysitting and taking these families, but these families, we might find that one child, but they have 5 other ones at home. And mom may be pregnant with one, so now we can touch that mom from the beginning. And we actually provide them with a 3-ring binder on how to organize their oral health and how to their overall health, how to organize their immunization records. It's just teaching them. It's health literacy. And if we talk to our pediatricians, I love my pediatrician colleagues that I work with, but half of them tell me, I feel like I'm talking down to them, and they're like, no, I didn't even know that. So if our healthcare providers don't even understand everything about healthcare, how do we expect the lay public to? We got to start from the bottom up and the top down and meet in the middle.
So I will chime in. I don't know if I have a great question or a great answer for how we change the narrative around consumption. The truth is that to me, the reason that we're there is laziness, and laziness from marketing and advertising. If you think about when money started coming into dentistry, it really came in at the same time the benefits came in, which was a big drive from the automobile industry. And so money was there. And as that was coming out, the low-hanging fruit was image and how I can tie into what's already in place. And so that has continued to be the drive. And as the top 1% to 3% of earners in the United States, which is where most of advertising is directed, got healthier, they continue to have to use that message to sell the additional pieces like bleaching and veneers and things of that nature. And then it became, how do I sell more of that? My hope is that the same people that got us here are going to be the same people that get us out. So I will end because I think I'm almost done. You guys know Bill Murray? All right, anybody watch the Netflix story? It's called Stories of Bill Murray. You guys know the Bill Murray stories? So it's, Bill Murray will just show up in a bathroom, put his, while you're at the urinal, he'll actually cover your eyes and say, guess who? And it's Bill Murray, and you turn around and he goes, nobody's going to believe you. And he leaves. True story. There's stories of him going to college parties and cleaning the dishes up, and that's all he does. And what was really unique to me and what I heard in this room was a lot of Bill Murray stories. And if you watch this documentary and you see he's been doing it for years, just one off, he'll show up and play soccer with a few people, and he shares his charisma with them, and it changes their lives. And now it is literally a whole thing where people, the idea is, how can you give of yourself just a little bit to make things better? And at some point, it becomes this big thing where they make a documentary about it, and people talk about how that 5 minutes, that 30 minutes changed their lives. And I say this because I hear that in this room, but I also hear other things around competition, of being the first to do the interprofessional practice, of wanting to be the first to publish, of being professionally jealous. And I want to end with this. Our healthcare system is awful sick. It is going to take a lot of providers and teams to make it better. Please, let's work together and have our own Bill Murray stories. And so that's it for me. Thank you.
So now we're going to break for lunch. Lunch will be served across